Cardiovascular disorders. We did talk about this when we talked this piece when we did the assessment. But I'm going to review some of this. Risk factors you cannot change. Your age. You can't change it. Peak years for a man to have a heart attack is between 40 and 60, and yet the mean age for a male having their first heart attack is 65.8. For a female, the mean age is anywhere, or peak years are between 60 and 70, and the mean for a first MI for women is 70.4. I don't quite understand how that fits, that the mean age for their first heart attack is greater than their peak years, but I don't know. That's what the author said, and it does fit with what the Heart Association says. Gender, again, something you cannot change. Men have greater risk than women until menopause, unless the woman is on birth control pills and smokes, because when you're on birth control pills, that does increase your risk for embolism and clot formation, and smoking we'll talk about more in just a moment. Family history. One more thing about gender. When women reach the age of 75, they have more heart attacks than men. And cardiovascular kills more women than the next 7 causes of death and exceeds the causes of death in men. About 38% of women die, only about 25% of the men die. The reason more women die is because they have smaller coronary arteries, and they are older when they have their symptoms, and the symptoms are different, and so they wait longer to seek treatment. But hopefully the new advertising that's out there that's talking about women and heart disease will get women to seek medical care faster. Family history. If somebody had a heart attack before the age of 65, in fact, if they had it before the age of 60, they've now doubled or tripled the risk of heart attack for their children. And race, if you're black, you have a greater incidence because of a greater incidence of hypertension. Some of the risk factors that you can treat are diabetes. With diabetes, your blood vessels are more fragile and you have increased lipid deposits. Men have a 2 times greater risk. Females have a 3 to 5 times greater risk if they're diabetic, plus twice the risk of death after an MI if they're diabetic. So survival is decreased. Your textbook says it's decreased by 3 to 4 times that of somebody who's not diabetic. Hypertension, women, it increases your risk, doubles it. If your blood pressure is increased just 10 millimeters, it increases your risk by 20 to 30%. Hyperlipidemia, as we mentioned, we want to keep our cholesterol below 200 unless you have known coronary artery disease, and then it's less than 180. If your cholesterol is over 240, you have twice the risk. My dad, when he had his one and only heart attack at 73, so it was not a risk for me, but his cholesterol was 450. That was the only risk factor the man had. When he started out as a child, he said his grandmother would give him a little bread with his butter, because the butter was always so thick because she made it at home. Dysrhythmias will decrease the amount of oxygen to that heart muscle. Whether you call it a dysrhythmia or an arrhythmia, it makes no difference. It's an irregularity in heart rate and rhythm that decreases the oxygen to the heart muscle. If you have a prolonged QT interval, it puts you at risk for sudden death, and we've talked about that in lab, and we'll talk about it more. Chronic renal failure increases your mortality from a heart attack by 30%. Vascular inflammation, again, your elevated C-reactive protein. And since they feel the inflammatory process is the major cause of heart disease, it's something that needs to be taken care of very closely. High homocysteine levels have been shown to be increased in coronary artery disease, heart attack, or stroke. Homocysteine is a protein in the body that's elevated due to diet and or genetic problems. Can be treated by giving the person more B6, B12, and folate, or by increasing those in their diet. Research is really kind of inconclusive as to whether that's helping a whole lot or not. But it doesn't hurt, because those are things we should have in our diet anyway. Cigarettes. I did mention that I would talk about cigarettes. and smoking. Secondhand smokers have a 30% increase of heart attack over a non-smoker and somebody who isn't exposed to secondhand smoke. Women have 2 to 6 times the risk over non-smokers if they smoke. The risk decreases to 50% after 1 year and then becomes the same as a non-smoker after 5 years. And if they don't smoke for 15 years, it's as though they have never had a cigarette in their life. And the problem is, not only is the cigarettes contain tar and nicotine and other junk, the nicotine increases the heart rate, thereby increasing the demand for oxygen. The tar clogs your alveoli, so it can't exchange oxygen as well as it's supposed to. And the other junk that's in the cigarette causes cholesterol to go from circulation to lining your arteries and thereby forming blockages. So smoking is really, 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 really bad for you. And if you smoke, I strongly recommend you quit immediately after graduation. Oral contraceptives alter your clotting factors. Hormone replacement therapy does about the same thing. It alters your clotting factors. Estrogen has been proven to decrease cholesterol levels endogenously, but if it's taken for hormone replacement therapy, it does increase the risk of stroke and heart attack in the first year of treatment. So hormone replacement therapy should only be used to decrease the risk for Alzheimer's and to decrease osteoporosis if somebody has it. Obesity, your diet, if your waist to hip ratio is greater than 0.76, that increases your risk, doubles your risk. If it's greater than 0.88, it triples your risk if you have a waist of more than 30 inches. The pear shape is better than the apple shape, because think about it, when you lay down, where does that weight go? Well, if you're pear-shaped, it goes to your waist. If you're apple-shaped, it goes to your chest, and it's harder to lift for your heart to work in that case. And if you're over 30% ideal body weight, your risk has doubled to tripled. A sedentary lifestyle increases the risk of deep vein thrombosis, stroke, obesity, blood clot formation, and stress. Think about it. You've got multiple roles. You're a daughter, a mother, a spouse, a husband, pardon me, a significant other, a worker, and then you try and be yourself, and you're a student. Stress can cause a lot of problems, and you need to know how to manage that. And that's a whole nother lecture. Coronary artery disease. Patients used to be admitted with the diagnosis of chest pain, rule out heart attack. Well, chest pain is a symptom. It doesn't really tell you what's going on. So the medical community got together, and besides that, insurance companies didn't like to pay for it, got together and decided to define acute coronary syndrome as everything that includes these categories here. Stable angina all the way up to acute MI. Now, stable angina is angina that is predictable, and your lesion is usually larger than 75%. But you know what causes the chest pain, you know what makes it go away, it responds well with nitro. Unstable angina is different because with unstable angina, it can occur anytime. And so you tend to have a more critical lesion with that. Your variant angina, also called princemetal angina, is due to a spasm of that coronary artery. This usually occurs at rest, like in the middle of the night. And the patient may wake up dead. Now, if you think about it, if you believe in an afterlife, you do wake up somewhere. So think about it that way. The characteristics for angina are on a table on page 435. Silent ischemia is something that occurs particularly in diabetics, type 2 diabetics, where the heart will not get enough oxygen, but the patient will have no symptoms. And in acute MI, there's a figure on page 440 that shows the different EKG changes that can occur with that. And the pathophysiology of coronary artery disease, the concept map, is on page 434. There's also a table on page 432 that talks about the timeline for atherogenesis. I think your textbook has done extremely well with the different tables and diagrams that are in there, so I'm going to make point of pointing them out to you through the entire lecture series. Hopefully you'll look at them. Treatment for somebody who's had a heart attack, oftentimes they'll use the acronym MONA, which stands for morphine, oxygen, nitrates, and aspirin. Not necessarily in that order. And you'll give your nitrates first unless you've had a systolic blood pressure of less than 90. Or if you've got a man who recently took Viagra or Cialis or any of those performance-enhancing drugs, because that will cause some severe hypotension in those patients. Oxygen, you want to keep their SaO2 greater than 90%. And you treat anybody who comes into the ER as an acute MI who has an elevated ST segment or a new left bundle branch block. The morphine, you're going to give 2 to 4 milligrams IV push, depending upon their weight and the degree of their pain, and the physician's order, of course. Side effects are, of course, respiratory depression and hypotension, because morphine decreases preload and decreases peripheral vascular resistance. The aspirin, you're going to have them chew between 162 to 325 milligrams. If they're a diabetic, they get the 325 milligrams. If they're not diabetic, they get the 162 milligrams to chew. Lifestyle changes, you want to decrease their caffeine. Keep in mind that coffee has 150 milligrams in 6 ounces of coffee. Tea has only 50 milligrams in 6 ounces, and colas have 20 milligrams in 6 ounces. Patients should avoid the extremely hot or cold food and or fluids, because that could precipitate some ectopic beats. But they can have cold liquids, and they can have some ice, just in moderation. Weight loss, you'd want them to lose 1 to 2 pounds a week if they need to lose weight. You need to do that by decreasing their calories by 500 to 1,000 a day. And you want to get their LDL down. And we've already talked about LDLs. There's a diagram on page 434 that talks about the treatment modality, and evidence-based practice, the collaboration, is on page 436. They may also receive IV antiplatelets such as glycoprotein 2B3A inhibitors, heparin, beta blockers, or calcium channel blockers. And they should also get ACE inhibitors that are not listed there, because ACE inhibitors decrease remodeling. But we'll talk about this a little bit further coming up. If somebody has an acute myocardial infarction, they can either have a Q-wave infarct or a non-Q-wave MI. Now, there is a table on page 442 that talks about the different sites of the infarct, the blood vessel that supplies that area, and their EKG changes. And I've written some of them here for you to look at. There's also a figure on page 440 that shows the 3 I's of an MI: your ischemia, which is T-wave inversion, ST segment elevation, which is injury, and your Q-wave, which is an infarct. We want, as nurses and physicians, medical people, to always have our patients have a non-Q-wave MI, because that means that does not involve all 3 layers. It may be just a subendocardial wall infarct, which patients should do better with. Q-wave infarcts means that they've gone through all 3 layers, and that Q-wave will never, ever, ever go away. It may get a little bit smaller, but it basically identifies just an area of dead heart tissue. So you don't want that to occur. Your non-ST segment elevated MI is a subendocardial wall MI. So that's where you have just EKG changes. We have just enzyme changes, not EKG changes. Complications from an infarct: you may have an aneurysm, particularly after an acute anterior wall MI. That left ventricular wall can kind of balloon out, or after a transmural wall MI. Treatment is an aneurectomy, where they remove the aneurysm, cut it out, and sew the muscle together. It can cause heart failure, emboli, angina, or ventricular tachycardia. An acquired ventricular septal defect can occur again, particularly after an acute anterior wall MI, and it will have a 35 to 73% mortality but thankfully there's less than 1% incidence of it. It is treated with an intra-aortic balloon pump and or vasodilators. Papillary muscle rupture causes mitral regurgitation. If it is complete, there's a 71% mortality without surgery. If they have surgery to correct it, a 40% mortality. Cardiac wall rupture causes cardiac tamponade, shock, pulseless electrical activity, and death. Survival is very rare. It usually occurs within the first 24 hours. But then again, if they survive that time, the next critical time frame is between 3 to 5 days after the infarct. Pericarditis, or Dressler syndrome, named after Dr. Dressler, will cause a friction rub and effusion into the pericardial sac. It's very painful, usually occurs about 4 to 6 weeks after a heart attack, and so the patient thinks that they're having another heart attack. It is treated with NSAIDs, and their cardiac enzymes will be normal. But they will show elevated ST segments, kind of global throughout every lead. Arrhythmias, if they develop sinus tach, they'll be on beta blockers, and they should be on beta blockers anyway to help decrease ventricular remodeling. They may have premature atrial contractions or atrial fibrillation. This will cause a decrease in your cardiac output because you lose that atrial kick. And it also increases your mortality by 34%. PVCs are used to treat multiform R-on-T PVCs, spurts of premature ventricular contractions, ventricular tachycardia. Again, you treat them with antidysrhythmics. And we talked about, and we'll talk about some of those. And if they develop an AV block, you want to insert a pacemaker. Heart failure, we're going to spend a whole bunch of time on that because that is a problem, and that's coming up. Treatment. Thrombolytics or fibrinolytics will dissolve any clot in the body. So they are not used as often because they find it's easier to take the patient to a cath lab and do PTCA. But if you are at a facility where you do not have a cath lab available and you cannot get to one in less than an hour, thrombolytics or fibrinolytics will dissolve that clot and give you the time to transport that patient so that they can have the cath and get rid of that plaque that's causing the problem later on. Your glycoprotein 2B, 3A inhibitors, IV, are oftentimes given prior to the cardiac cath and during the cath. They can also be given to patients who have problems with other anticoagulants. Anticoagulation with heparin if you have a risk of emboli, or you can use low molecular weight heparin. You give it IV or sub-Q. You usually get 60 units per kilogram IV push, followed by 12 units per kilogram per hour to keep that PTT 1.5 to 2 times the control for at least 48 hours. And then you start them on Coumadin. They will usually be on Coumadin for about 6 weeks. Now remember, you cannot give low molecular weight heparin IV. Your angioplasty is your PTCA, percutaneous coronary angioplasty. You learned all about that in 224. Pardon me. Your coronary artery bypass graft, as I mentioned earlier lecture, you can do either the keyhole or the traditional. They're usually in the hospital about 4 days, 4 to 7 days. For the traditional keyhole, they're in the hospital for 36 hours. Supplemental oxygen, you want to keep that SaO2 90% or better. Morphine, we've already talked about what to do, how much morphine to give. Your beta blockers will lower your blood pressure, decrease your ventricular dysrhythmias, and prevent reinfarction unless they're already in shock. And then you usually start off with lower than therapeutic dose with the beta blockers and then increase it. Your ACE inhibitors are given to decrease ventricular remodeling. Your tight glucose control keeps that blood sugar down to about 140, and this does decrease mortality. Your evidence-based practice guidelines for STEMI and non-STEMI are on page 452 to 453. Your nursing diagnosis is page 451. And your symptoms of an MI are also on page 451. Sudden cardiac death can occur. There's a list of causes in a box on page 455, one of which is a prolonged QT. It accounts for those who die before reaching the hospital or for those in the emergency room, emergency department. Men, it occurs 3 to 4 times more than it does women. And that finishes this section, and we'll continue with heart failure in just